waiting for Dr. Chopra. But Dr. Elder is here, and we're going to start with his talk about massive DVT, PE, management of massive PE. And Dr. Elder's from Wisconsin, right?
Michigan.
Michigan,
Right,
I'm sorry. I get it mixed up. So welcome. He's an interventional cardiologist. We've welcomed him to the podium before. He's going to talk about his management of massive PE. Thank you. Do you know how this works?
Yeah, is this?
This is see this nice big
That's an
arrow?
pointer.
And you can advance. Oh, it's backwards, though. It advances from this side.
Mm-hmm. Very good. Thank you. We'll go ahead and get started. No disclosures. PE, as we all know, is basically a clot inside the lungs, typically coming from anywhere from the upper extremity to pelvic, but more commonly through the lower extremity. We know it's a public health crisis where over 200,000 patients die of PE. Just as a rough estimate, it's 5 times more patients that die from AIDS, breast cancer, and accidents. We can divide PE basically into 3 categories. We have massive PE, submassive, and non-massive PE. When we're talking about non-massive minor PE, that's the majority of the PE that we deal with. And these patients have hemodynamic stability, there's no RV dysfunction, and there's no myocardial necrosis. The massive PEs, these are higher risk patients that have hemodynamic instability. They require some type of inotropic support. They're crashing. These are the coded patients. They have no pulse or very low blood pressure. And then we have the category of submassive, which is in between the two, the massive and non-massive. And these patients have a somewhat stable blood pressure, but they have RV dysfunction. And they also have myocardial necrosis. But they mainly have RV dysfunction, and they can define it either by echo or CT scan based on the RV-LV ratio, and as well as elevated BNP and some EKG changes. And so if we risk stratify these patients in the category, the majority of patients are non-massive PE, and these are about 55% of the patients that we see with a 15% 90-day mortality. The submassive PE is about 40%, and the massive PE is less frequent, 5%, but they have the highest mortality, 90-day mortality. And if we just a quick history and physical on these patients, most of them will have dyspnea, hemoptysis. On physical exam, they mainly tachypnea. And if we look at diagnostic tools that we could use to diagnose PEs, the D-dimer is helpful as a negative predictive value, as we know. Typically with patients that are low risk, we use 500 as a cutoff and 275 for the moderate or high risk patients. On EKG, we typically see sinus tachycardia. BNP and troponin are helpful, and I'll talk about that soon. All patients, I think it's the standard with massive PEs and submassive PEs that we get a venous ultrasound. Echocardiogram we'll talk about later. VQ scans are helpful in patients that are low risk to have a low probability, or are high risk patients that have high probability. The intermediate is not as valuable. And then, of course, we have other modalities such as CT scan, which we'll talk about. For the biomarkers, the BNP and cardiac troponins are very helpful, but they've been associated with elevated troponins in patients that have a higher mortality, as well as BNP independently has been shown higher adverse effects. And in combination, there's an increased mortality and adverse effects. If we look at the literature real quick, we do know that well-established echo findings show that the right ventricle, left ventricle ratio greater than 0.9 is an independent hospital mortality. And we do know that the ratio greater than 0.9 has a higher adverse events within 30 days. And we also know that based on echo, there's a 40% higher mortality at 3 months with these patients that have RV hypokinesis. Basic echo summary in the acute pulmonary embolism, they have right ventricular dilatation. These patients have right ventricular hypokinesis and some septal deviation. There's this static image of a right ventricular dilatation, normal on the left, and on the right of the screen you have a dilated right ventricle. The right ventricular hypokinesis can be quantitatively assessed. Most of the time we can use McCulley's sign, and this is what this is free wall hypokinesis with sparing of the apex. And this is just a diagram showing a static image of a septal deviation On the left, showing the bowing towards the right ventricle, which you normally see in normal echoes, and then you're seeing bowing towards the left ventricle and a dilated right ventricle. We also see septal deviation, and the diagram on top shows that the RV pressures overloading in diastole, causing a D-shaped, and then in the bottom is doing systole, showing that the intraventricular septal flattening. And so how do we manage these patients that have massive and submassive? As we mentioned earlier, the non-massive PEs, the majority of the patients will be treated conservatively. The massive PEs that we see that have a high risk, these patients have to be aggressively managed. These patients are coding, they're very unstable, and they have a very high mortality. Then the question becomes, what do we do with the submassive PEs, the ones that are in between? And this is a little bit topic for debate, but I'm an advocate of being very aggressive. And the reason is that these patients with submassive PE have recurrent PE. They're 4 times higher mortality rate. They have a 44% chance of developing chronic pulmonary hypertension long term. And we do know that there is a higher rate of RV hypokinesis, and at 3 months have a higher mortality rate. And anticoagulation itself does not fully dissolve the clot. And so the majority of these patients, if we look at the patient profile, the minor PEs, we said lower mortality rate. The massive PE, much higher mortality rate at 3 months, and submassive is about 20%, relatively speaking. So the treatment options we have, the management of these patients, we have anticoagulation either with unfractionated heparin, low molecular weight heparin, or factor Xa inhibitors. But they actually rely on endogenous TPA to resolve the clot that's in the pulmonary arteries. We have systemic thrombolysis, but it has a higher rate of bleeding. We have catheter-directed thrombolysis, but it still haven't been shown enough evidence with double randomized trials, but it has been shown with some data, limited data, that is superior as far as bleeding is concerned. Then we have the mechanical pharmacological interventions. There's no significant data to suggest that it's superior, and there is a learning curve involved. Then, of course, we have surgical embolectomy, which these patients, very high rate of mortality overall. If we look at the larger registries, we see that patients that actually went to surgical thrombectomy was actually a very small percentage. It's from 1% to 2% in the different registries. And the ones that did go had a higher mortality rate. And so we do have some evidence of just using catheter-based interventions, and we're going to just quickly talk about some of the options. The ECOS catheter is a catheter that we use basically after you pass into the thrombus. The technology is basically used ultrasound to relax the fibrin strands and then penetrate into the drug into the thrombus, and then through the ultrasound it pressures the drug into the thrombus, and so you could use less of the drug overall. So the advantages are we shorten time for recanalization. There's a significant lower risk because you're using less TPA, and it's very focused. And so one of the data that helps support this is the recent in the ACC was presented as the Ultima trial. They took these patients with massive and submassive PEs, and they had to have an RV-LV ratio greater than 1, and basically at 90 days shows that compared to just heparin alone, that there was a primary reduction in the RV-LV ratio, as well as 90-day follow-up shows normalization of the systolic RV dysfunction compared to just heparin alone. And so I want to go over a couple of cases. This is a case that we had, me and Dr. Rabbani, who's in the audience, had this patient, 66-year-old patient with malignant mesothelioma, presented with ongoing shortness of breath, finally decided to come into the ER, is unable to walk just a few feet without getting short of breath, and in the ER they diagnosed in the CT scan, they had a very large saddle embolism. Patient was severely hypoxic, became very unstable, and it was taken to the cath lab, and this is the echo finding at baseline, and this is at presentation. He had an echo prior, and he shows the RV dilated. And so subsequently, the patient brought to the cath lab, and we see the angiogram here. We see this there's a saddle embolism right in the main trunk, and you're seeing lack of perfusion and the thrombus extending all the way to the left upper, and also the right upper and middle lobes, and there's just lack of perfusion throughout this area. This patient's blood pressure was like 60/0 at the time. And you can see in the selective views of the left lung that there's the saddle embolism is extending all the way towards the left lung with no perfusion in the upper lobe. And this is a static image CT scan of that saddle embolism that we're showing. And so we actually took a woolly wire, took an ECOS catheter and placed it selectively into where we thought the greatest amount of thrombus was. We did this actually bilaterally. And post-treatment, after an entire day, this image doesn't show up properly, but you can see actually a little bit of thrombus more on the right side, so we redirected the ECOS selectively to the right. Because there was such thrombus burden and because there was ongoing DVT at the lower extremity, we decided to place a filter temporarily and retrieved it later. And so pre-treatment, this is a CT scan of that saddle embolism, and this is a static image as well of the clot burden. And then we see post-treatment 2 days later that the thrombus, the saddle embolism is gone. There's some remnants of thrombus, but it was enough for us to stabilize the patient and subsequently just put him on oral anticoagulations. This is another case, myself and Dr. Genjo, I did a 67-year-old patient with hypertension, diabetes, who had leg swelling and subsequently came into the emergency room as well. And this patient in the ER at bedside had RV dilatation, hypokinesis with normal systolic left ventricular function, and had an elevated BNP, but became too unstable to go to CAT scan. And subsequently, the suspicion was very high for pulmonary embolism, and we took the patient directly to the cath lab. And this is the echo that we found that you see that there's a huge right ventricular dilatation with a ratio greater than 1, when you can see the septal bounce as well, and you see the D-shaped in the cross-sectional views. And this is the angiogram that we did on this patient. Is a huge clot burden you see at the lower lobe, and you see also the lack of perfusion throughout the lung field. And subsequently we took a 12-centimeter ECOS catheter. We did TPA for 24 hours with 2 milligrams for 4 hours and 1 milligram an hour. That's actually a typo. And this is us with the ECOS catheter selectively in there. And this is an angiogram prior to the intervention. And you see it post-intervention, and you can see clearly good relief of some of the thrombin, and you see better perfusion in the lung fields. And so this is a second case, a huge thrombus as well. And this is just a CAT scan compared to the angiogram where it was at. One of the other devices you can use, the AngioVac, it's also on the market. It's a very large device that you can use. This is one of the cases that we did. It uses a 22 French catheter, and then it comes across with return with a 16 French. And this is us taking the catheter up to the lung field in a patient with a huge pulmonary embolism. And this is us in the LV identifying some of the thrombus. You could also use AngioJet, another tool that you can use in these patients with thromboembolism. But the take-home points that we're going to bring out here at the meeting is that the catheter-directed thrombolysis for unstable patients, hemodynamic stable patients, it does help save lives. And we have a series of these at our medical center, less bleeding time. But the most important thing is prevention, preventing these patients developing PE and DVT. And so the treatment of massive and submassive PE, I think, can be treated endovascularly, and especially because very rarely these patients end up in surgery, the ones that are very unstable. And the reason when we got involved in this is because PE often mimics either non-STEMI or a STEMI. And most of these patients will come into the ER or ICU, or as we have in our institute, a very large cancer center, and we have a lot of these patients who are hypercoagulable who are in the ICU and subsequently develop PE. And I think as long as you have a strong foundation in endovascular procedures and you have a good understanding of the hemodynamic instability of patients, that this is an area that I think is going to require a little bit more data, but subsequently can be done endovascularly. Thank you.
I have a question for you on those the first two cases that you showed. Did you put a balloon up to try to fragment the thrombus before you used the ECOS?
No, we didn't. Now, in the other cases we have, but these cases we didn't because we were able to wire right into it. It was such fresh thrombus that we had no difficulty establishing recanalization.
But my understanding is the fragmentation of the thrombus, when it's totally occluding the whole major branch like that, is that it permits perfusion right away. And then the lytic therapy actually has more surface area to contact the thrombus, and so you get more resolution of thrombus. So that would, I mean, maybe you think it defeats the ECOS part, but I think it actually helps patients get past that dreadful period when they're unstable.
There's two things that we factor in. A lot of cases we have done it this way with balloon angioplasty, and it's exactly as you mentioned. The pressures are very low, 60 over 0. It's very powerful. And as soon as you do a little bit of angioplasty and there's just some recanalization, the blood pressure goes up and patients have somewhat stability. But we stopped doing that because in our observation with a lot of these pulmonary embolisms that we've been doing is that even the massive ones, as soon as we can get an 035 wire across the thrombus and place the ECOS, after a few hours they actually stabilize. So we've been able to actually get through the thrombus, have the ECOS catheter, the majority of it placed into the thrombus, but also in a normal segment, so allowing it to trickle down into the thrombus itself. Yeah.
Any other questions? I think it'd be interesting if we could compare the different modalities and their effectiveness, but they're just, these patients are few and far between. No one has a big series. I think I had 12 in my series when we were treating massive PE. So most people die with this condition. Right. And so no one has a huge experience in any one hospital to actually do a trial, unless we do a multi-center trial.
Well, let me ask you this. Are you from the school of thought of what I call the helicopter technique, where you take the catheter and twirl it? Because we've seen with a lot of the unstable patients that when you do that technique, they tend to become a little bit unstable.
Well, anything that can induce a cardiac arrhythmia will make them worse. But I thought it was interesting that most people from a PE, they don't die, they don't suffocate. It's not because they're not delivering oxygen or blood. They actually die of a cardiac arrhythmia when they die instantly. So what I've found is just fragmenting the thrombus switches it to a more favorable configuration, and they start to recover. So I don't leave that massive occlusion there at all. Even if I can get a guide wire through it, I'll try to break it up. But we've tried every kind of catheter to fragment it. But. Yes, question? Can you speak just a little louder, please? That's interesting. And do you have a percutaneous, what do they call, defibrillator or something, or pacemaker ready in case they go into a... Right, you probably, well, because of the difficulty of diagnosis, a lot of people probably died during that interval when they think it's an MI and it really wasn't. Yeah, I know.
Yeah, they end up going, it mimics it so closely to MI that the patient goes down the track of an MI and valuable time is wasted.
Any other comments? Is it really helpful? Thank you very much.
Thank you.
It's good. We're going to, Dr. Rodriguez has been, had some kind of conflict with speaking in the other room as well as here. So we're going to ask Dr. Chopra if he would come to the podium. And hi. Great. And you have this talk on pelvic congestion syndrome. We've had a few mentions of it this morning. And Dr. Chopra is a respected interventional radiologist here in the Chicago area, and he's going to talk about PCS, I guess. Okay.
Great. Thank you so much, Pat. How many of you in the room treat pelvic congestion syndrome? 1, 2, 3. So it's, hi. Obviously, it's not a very, very common condition, But it's quite interesting, especially if you treat varicose veins, you realize the same thing. And if you treat varicocele in males. But the biggest message with this is it's so undiagnosed, but also very common, and then gets trapped at the gynecologist's office if the patient gets there too. So we'll talk a little bit about that. In really the best way even to start with this is not the technique of doing the embolization, because that's probably the easiest of all. It's really about how to find a way to diagnose it, find these patients, and then manage them. So as I said, very underdiagnosed and very poorly managed, and mainly due to the lack of awareness. And most of these patients, all they want is to be healthy and pain-free, and it is very misunderstood in the general population, definitely in the primary care population, and even in the GYN community. And it becomes a diagnosis of exclusion. They've had chronic pain for a very long time. And it's been quoted to be as common as 10% of the general population of women, and that's very high. And in the 18 to 50 year range is as much as 15%. So over 10.5 million women in the US alone. And this is a significant family burden. It ruins the relationship. This is the childbearing age, active sexual age. They have painful sexual intercourse, destroys that relationship, causes a lot of issues within the family, the kids, et cetera, especially now more and more women are in the workforce. And typically occurs after pregnancy. They may have kids to worry about as well. And the concept is very much the same as that happens with varicocele. So it's really anytime you're fighting gravity that this comes into play. And pregnancy itself significantly increases pelvic venous flow and obviously causes all the dilatation. And it's most likely just as it's happening in the legs after pregnancy that these ovarian veins don't go back to being normal. So really one way to think of this is pelvic varicose veins with valvular insufficiency. So what are the symptoms? It could be as vague as vague back pain, pelvic pain, leg aching. So they go through all these different diagnoses and workups first. They may have abnormal vaginal bleeding, so they go through the workup of that as well. Some of them do have large vulval veins. They have painful coitus in them, but they're shy about it. They don't tell anybody. That's if they even find out themselves. And they, on examination, may have ovarian point tenderness, but then they're misdiagnosed as having a PID or something else going on. Frequent urination, but then that's diagnosed more as a UTI as well. So it becomes very difficult when they have difficult menstrual cycles. They start workup down the pathway of fibroids and different things that go on as well. So the pain lasts present much of the time. When they wake up in the morning, just like varicose veins, the pressure is zero. They're supine, everything's been okay. They don't feel much. As they get up and start increasing the activity, after a while, the pressure starts. And that history is very important. It definitely gets worse as the day goes on. But I usually tell them, if you work the night shift, then it's going to be as you're standing up at night. So really, it's with standing that this happens. It'll be exacerbated by prolonged standing. And then when they take a nap, lay down, feel better, and they go back up, the same problem starts again. A lot of them go to the emergency room, they get checkups, they come back, the evaluation's negative. Then this may also be related with migraines, so they get into a kind of a syndrome that they're not sure it's psychosomatic, et cetera. So they really bounce around a lot. Pills are not effective. The general painkillers are not effective, and they go again a long time. They're frustrated, families frustrated, partners are frustrated. And really what's happening here, if you look at the pictures, it looks like I can point today, that in the ovarian veins, and more common on the left side because it's emptying into the renal vein, and you may have a incompetent valve that causes reflux. And they also grade this, which I'll show you in a moment. But really it's the same concept as we see with venous insufficiency in the legs and varicose veins. Some grading helps, but again, it's only on angio, but that's the time you're actually going to embolize this. It could be grade 1 where it's halfway down the ovarian vein, 2 where it's going all the way down to the uterus, and sometimes you'll see this filling all the way through. Some of these will have laparoscopic examinations for various reasons. Okay. They may have they'll have laparoscopic examinations. They can see some very large varicosities in there. So really half the time they can detect this with very good history. And so because we see a lot of fibroids and we see a lot of varicose veins, and sometimes you're treating the varicose veins, you've treated the saphenous, et cetera, but you're still seeing collaterals and you follow it up. So we make it a habit to examine the lower abdomen, talk to them about it, ask these questions, and go down there. But you definitely have to exclude all the other causes. So for fibroids, we routinely do MRIs, so we make sure we've pay some attention looking for those things, whether it's endometriosis, pelvic adhesions, and things like that. So you exclude those things, of course. But taking their history seriously, their complaint seriously, is the first step. And to really ask them and not just pass it up, because just about the primary care doc, GYN, and a whole bunch of other people have done that, and then they get anxious, there's depression, all these other things, so you got to look through that. Examination obviously becomes important. You know, we are shy usually of doing a pelvic exam, but in this diagnosis, it becomes a little important at least to examine to make sure you're seeing some external varicosities, especially vulvar, and a lot of these go into the leg. As I said, I found one patient where we were treating the leg varicosities, and we found out, you know, we've been doing this, we've treated the saphenous, everything else, but she still has some ways that if we followed it through, got further exams and found this. Imaging studies, ultrasound, CT, MR, MRV, but ultimately come down to venography. When it's really severe, then ultrasound obviously is very easy to find out. And you can see it's a massive network of veins in the pelvis. On CT, you'll see different branches fill up as well. Laparoscopically, sometimes they see that. MRI usually is a good way, because especially when we're evaluating them for fibroids, endometriosis, et cetera, you'll see flow wides on different images. You can see. Earlier we used to order them with and without contrast, but now we don't. With contrast, it's not really necessary. You can really pick them up even without that. If you do an MRV, oftentimes you'll catch it. And obviously the embolization, which is the key, the technique is very simple. You do a essentially go up the puncture of the femoral vein, you're up there, you go into the renal vein, you go down. With varicocele, earlier we used to only put coils. Now we actually take a little Sotrodecol, we foam it, we put coil distally in, so we use the same technique here as well. And there's not a lot of papers talking about it, but the bottom line is you want to shut down the ovarian vein. But you want to definitely go through from the beginning and work them through this. So there have been all kinds of medical treatment, but it really doesn't work as much. Surgical is not recommended because they go through this embolization is just so simple, but the gynecologist that you're working with is really the one you have to convince. I've dealt with a few, they want to do surgery, they want to open, they want to do laparoscopic, and really it's an economic issue for them, and they don't want to let go of the patient. It was just like we did with fibroids. And as we've talked a lot on the venous side, there's so much lack of awareness on so many things, DVT, PE, varicose veins. This is just another thing that comes into play. As we talked about embolization, outpatient procedure, they come in often, I give them some pain meds before doing the procedure as well, and outpatient, they're home by the end of the day. It's fairly easy. Routine, simple catheter technique, go up the femoral vein, up the left renal. It's rarer on the right, but if we see a reflux go all the way through, then I'll go up and do the right as well. Side effects, extremely rare and uncommon, but these have been described: infection, you see migration of the choroid. They may feel a little increased pelvic pressure, just like they feel with varicocele as well. Some bruising at the site, rarely breathing. It's a femoral veins puncture, so that's not a big problem for them as well. More than 80% will get relief very soon. But they may feel that this takes some time because of the congestion that has occurred with the tissues for them to really go back to being completely normal, but they start seeing the benefit almost right away. And this has no adverse effect on pregnancy later. So bottom line with pelvic congestion, it's not a very difficult or complicated disease to treat. It's really finding it. It's very similar to how varicose veins were for a very long time. No respectable surgeon, at least when I did training, would touch varicose veins. They thought veins were this, and I remember one surgeon telling me, oh, when I retire, I'll just start doing those injections a little bit. Versus now, it's really, there's a lot of focus on this. This is kind of in that same pathway, and community by community, there's a variance in what the awareness is. So with that, I'll stop on this, and any questions, happy to answer them. Yes, please.
I have a couple comments. First, I mean, I see a good number of these patients, and these women, they're always devastated, they're always depressed, they've always been told to be crazy. There's always psychosocial overlay, because there really is no such thing as somebody who doesn't have psychosocial overlay. And oftentimes, they have already had laparoscopic, they've had laparoscopy, which it can be missed, because when they do
They're
laparoscopy, they pump the belly full of CO2, and it collapses the veins. So for me, the gold standard for this is renal is cavography and left renal venography with Valsalva, and actually looking for the vein, because I've seen MR, CT normal, and had women have it. And the second point is that a lot of the time the women will get better for a period of time, and then their symptoms will start to come back, and that's because the internal iliacs have taken
Collaterals.
over, and now you've got a wad of vessels feeding from the internal iliac. So I would say that at least half of the patients require embolization, not with coils, but with sclerosant of the internal iliac veins.
And as a technical point, it's important not to just drop the coil at the top, at the ovarian vein, but to actually come down, which is very similar to what we do with varicocele now. And again, it's the same battle with the urologist there. They see their laparoscopic procedure, and I've had so many of them go, I'll just clip it, it's okay, I'll just clip it. But then they come back because they'll develop collaterals from elsewhere. So two very good points. Another question or comment?
Actually, I have two separate questions.
Sure.
One, with regards to these patients, I've had a couple cases where, on CT, patient has obvious dilation of the ovarian vein, pelvic varices, yet their symptoms, it's incidental. They come in for like right lower quadrant pain, and when you talk to the clinician, their symptoms don't really have any of the typical characteristics for this condition. I guess my question for you, do you just leave all those patients alone, or presuming that maybe they'll develop symptoms in the future, or?
See, it's really important because as you've heard many times now, they are bounced all around, and
Right.
it becomes a diagnosis of exclusion. So they'll go through this workup, there's nothing else, you suspect it. And at that point, you look for some signal of what's possibly happening, and you investigate that.
Sure.
So I would not just leave it alone. It
Sure.
wouldn't be the first diagnosis.
Right.
So you want to exclude all the other things first, and then maybe do a cavography and Valsalva and venography, and see if that helps you.
Actually, Robert, there's another side to that, because the first paper to show that there was probable association between pelvic congestion and the CT findings of the big left ovarian vein, the authors had to sort of recant the paper because of the fact that the number of people who had symptoms consistent with congestion, pelvic congestion syndrome was low. And then they went back and they actually interviewed all these people, and the percentage came way up till it was obvious that there was an association between the two. So what they're probably doing is that they've talked to people about their pelvic congestion syndrome, or they've not talked to anybody about it because it's embarrassing enough. And if you really ask them, you'll find out these people do have the symptoms.
Just one other thing.
Sure.
Do you have any experience treating these people who have this condition post-op, i.e. after hysterectomy and ovarian resection? Because I actually treated a patient like this, and I didn't have too much experience with this aside from fellowship. And it had to be a 2-session thing, and this lady had horrendous anatomy. She had like multiple collaterals, one main ovarian vein which split. You couldn't get down
Wow.
very far. She had connections with the lumbar plexus. She had a separate renal vein going up along the thoracic plexus and internal iliac. Actually, we successfully treated her, me and my partner, but we worked on her twice. First time 2 hours, second time 3 hours, and her symptoms finally went away. And she did have typical like 10 years of symptoms. But do you have any recommendations in terms of approaching that? 'Cause
That is unusual. So it's actually the same. You just walk your way down this, and this becomes kind of the last diagnosis. So one of the things, it's a caveat which is very important, is not to make this your first diagnosis. Walk in and you go, I think you have pelvic congestion. You're doing a cavogram and a venogram and embolizing stuff. I think you got to exclude all the other common things first, so that they don't, because they'll have vaginal bleeding. You got to work up the vaginal bleeding, make sure that's okay, or all the other things. But that's very unusual, though. That's very unusual.
Do you think there's how often do you see iliac compression associated with your ovarian vein?
I haven't really appreciated that, because when we're doing the venography, it's up there. So I haven't really looked for iliac compression per se, but not that often because then they would have symptoms in the legs, which we haven't seen anymore. So answer is I haven't seen that. I don't know if anybody else has. Do you have you?
One more comment, since everybody here is doing veins. When you see varicosities that are predominantly posterior thigh, and the saphenous looks okay, feel free to look at the pelvis because that's where it's coming from.
And that's something we do routinely now, because you can have perennial branches just feeding a lot of them. So now we've made it a habit to kind of follow through even with ultrasound and see what's happening and not just stick with the saphenous. But for something like this, when you've treated everything and then you find some big branches still popping out, then you know there's something coming from the pelvis and you can trace it back up. So, very well, thank you.
We could talk a long time about
Yes, we
that.
can.
Thank you very much. Okay, thank you. We have Dr. Hunter is scheduled to speak, but we have two physicians who have some travel. Dave, would you be able to just talk after a little bit? Okay. Okay, thanks. Dr. Rodriguez is going to speak after Dr. Razavi, and Dr. Razavi is going to be able to, is that okay with you now? Present your talk on, you're going to come up and talk about central venous obstruction, actually. And his first talk was shifting paradigm of etiologies, and the second talk was the complex reconstruction of central venous veins in patients who have dialysis issues. So we'll do both of those talks, then we'll do both of Dr. Rodriguez's talks to follow. Okay? Thank you.
Thank you, Patty. So the first topic is SVC syndrome, and these are my disclosures. The SVC syndrome is symptomatic. Obviously, those are the ones that we do treat, and the rapidity of the obstruction determines the presence and severity of the symptoms, which include upper extremity edema, vague shoulder, neck discomfort, facial neck edema, dyspnea, stridor, things of that sort. CNS symptoms can occur late in the process, or if the occlusion is acute. Risk factors: multiple central venous catheters, pacemakers, defibrillators. These two are becoming more and more common. Patients with thrombophilia, malignancy has traditionally been the most common cause of SVC syndrome. Extrinsic compression, tumor invasion, so on and so forth. The etiologies in the symptomatic SVC syndrome, malignant is the most common. Traditionally, that has been the case. It still remains the most common cause of symptomatic SVC syndrome. And the benign causes are usually due to central venous catheters. Dialysis-related infectious and inflammatory causes are also in there. Now, in terms of treatment, if there's acute thrombosis, anticoagulation is the most common way that they are treated, and that's because a lot of people who see them really are not quite informed as to what other options these patients have. Although thrombolysis in the upper extremities is far more common than in the lower extremities, because doctors recognize those more than, or associate that with better outcome than with lower extremities. Anticoagulation and central catheter removal is another way to treat those, but you lose the access. In our center, in symptomatic patients, they usually get catheter-based therapies, and then we decide what to do with the central venous catheter, or treat the underlying lesion and address the culprit lesion. In chronic occlusions, again, as I mentioned, malignant is the more common cause. In terms of benign causes, angioplasty and stenting. Angioplasty alone, most of the time, if they have complete occlusion in non-dialysis patients, is ineffective. You have to support it with stenting and then decide what to do with the catheter. In terms of malignant ones, radiation and chemotherapy is effective in most of these patients. The problem, it takes time to get there. Stenting is immediate. The symptoms are relieved 1 or 2 days later. Malignant syndrome, historically, as I mentioned, most common causes, most common etiology, and radiation therapy and chemotherapy are used to be the first-line therapy. Currently, the endovascular management of these patients is the first-line therapy. I caution you in terms of diagnosis of these patients. If they have lymphoma, be careful. Lung cancer is obviously you can drill through and stent them. The lymphoma, because they respond very well to treatments, and the size of the SVC may change as the lymphoma regresses, so be careful. This is an old case. And you know it's old case by the way we treated it. You'll see it. This is post-thrombolysis. The patient has had radiation. This is a typical sort of scarred down vein after radiation with chronic clot component. This was treated by sort of a double-barrel SVC, which I don't do particularly with the wall stents anymore. And this flow was reestablished, and of course, you see a significant improvement in the patient's conditions. That's the way we used to do it in the 90s. So in the 2000s, this is what we experimented with, and we've gone away from this approach also, and I tell you why. Here's a patient with bilateral brachycephalic and upper SVC occlusion. Here's the reconstitution of the SVC. This is an oblique projection, so you can separate the azygos from the SVC. In a lot of patients, if you have an AP projection, these two may overlap, and if the flow is through the azygos, you may confuse that with the SVC and feel that the SVC is open. It may not be. In this case, the SVC is patent, so we see that the brachycephalics are out and the upper SVC in a highly symptomatic patient who has cancer, so needs all the accesses. The way we treated these patients in the 2000s or so is by creation of these fenestrated stents. So both at this location and this location, these stents are fenestrated. And so the result is that you have access from both jugulars and both subclavians, and SVC is patent. So this was well and good, and we treated a number of patients with these, except in the long-term follow-up, we discovered that at the points of fenestration, we have a high rate of restenosis in these patients. So we've gone away from that, and the way I treat them now is by sort of a short double-barrel stenting using nitinol stents. And in the next talk, I'll briefly describe why that is. Malignant SVC syndrome, this is one of the largest papers out there in terms of the data on stenting, 149 patients. Note that most of these were small cell and adenocarcinomas, with only 22 being of other. Some of those were lymphoma. 72 were only SVCs, the remainder had SVC and brachycephalic veins. Complete clinical response was seen in 82% of the patients within the first 3 days, and partial response in 15%. So as you can see, 97% of these patients had resolution or complete or significant improvement in their symptoms almost immediately and within 3 days. Mean survival time was 6 months in the cancer patients, and the primary patency during that time was 86%. This is very typical in this patient population. Secondary patency much higher. Now, poor prognostic indications were presence of adenopathy, no treatment before or after stenting, and stent thrombosis. I totally agree with that stent thrombosis thing. In our malignant population, anytime there's stent thrombosis, even in the lower extremities, we know that that patient has a poor prognosis in terms of survival. This is the Kaplan-Meier curve for the stent patency, and these are survival curves showing those patients who don't get any treatment after stenting really die very quickly. Now, the other important message from this paper was that the presence of a stent did not impact radiation or chemotherapy. A lot of oncologists and radiation oncologists worry about stent interfering with radiation. It really doesn't. This is something we've known for a long time. And therapy after stenting improves survival, and it should be the first-line therapy, the recommendation of these guys in 2009, but this has really been the first-line therapy at our center for a long time. This is a sample of other literature on malignant SVC obstruction at various years, various years of publication, different number of patients, and with a weighted average of 87% primary patency in these patients and 94% secondary patency. Remember that the lifespan of these patients is fairly short because they're all malignant, and therefore these patencies are quite high because of that reason. Now, summary of malignant SVC obstruction, radiation and chemo work. However, the problem is it takes time and you have a pretty high rate of recurrence. EndoVascular stenting, which should be first line of therapy, has a very high rate of symptom relief very quickly as opposed to radiation. And durability is not an issue because, first of all, durability is great, and secondly, the life expectancy in a lot of these non-lymphoma patients is somewhat limited. Benign conditions, the etiologies are mostly catheter-related, mediastinal fibrosis, radiation, infection, hemodialysis-related. These are all also other causes. Dialysis and catheters are the most common causes. Stenosis, angioplasty first, especially if you're in the dialysis patients. Stent for angioplasty failures, in my opinion, when the veins completely occlude, even in benign conditions, they rarely respond to angioplasty alone in non-dialysis patients. They need to be supported by stenting. And let's look at some of these examples. This is a 20-year-old female with treated lymphoma, had multiple central venous catheters and now has evidence of SVC syndrome. This was approached from a jugular path, and as you can see, that this is the bottom of the SVC occlusion. I really don't like to see these rounded occlusions. That means that we have to use sharp recanalization. And this is going into the azygos. So this was recanalized from above and below. For these, I use transeptal needles. Transeptal needles are fairly easy and fairly quick, and you have some control over the angulation. Although you don't want to angulate in this patient, it's SVC and everything is straight. This was placed from below, so I know where the right atrium is, so we have a target. Sometimes I put a pigtail catheter over here and do a sharp recanalization, or you could do sharp recanalization backwards. Angioplasty alone, typically angioplasty does not work, and this is the results of the angioplasty alone. And this was stented with a balloon expandable stent and with good results. Now, in terms of outcomes, fewer papers in the literature in non-dialysis related central venous occlusions, and with a weighted patency of about 66% and secondary patency of 85%. Now, this weighted patency, if you look at these papers, they're not all 1 year. For example, Key's paper is a 2-year outcome. So some of these are more than 1 year. And what drags everybody down was this particular paper. And there were a lot of issues, technical issues with this particular paper. If you exclude that, you can see that really the outcome, the primary patency is in the 70% or so at 1 to 2 year. The algorithm for central venous occlusions that we follow in dialysis access patients, if they're symptomatic, they get angioplasty, stent for angioplasty failures. If they're asymptomatic and the stenosis is thought to be the culprit for access failure, they get angioplasty. If that fails, they get failure. If they're asymptomatic, really we don't touch them. And the reason for that is that the natural history of intervention in asymptomatic patients is actually poorer if you just leave them alone. Complications, pulmonary edema can occur. Stent migration, really, this is a technical failure. This is a technical problem. If you're undersizing or you're misplacing stents, you have to make sure that you put it in the right place, and in the lymphoma patient, make sure you're not undersizing those stents. Perforation is rare. It can be into the pericardium, into mediastinum, into the pleural space. This is a case of Matt Morrow that I borrowed because this is an interesting complication. Now, this is the reason I show this. This is not for historical purposes anymore. This may soon become an issue again because the industry is developing venous stents that are much higher in radial force. And if you put those around corners where the stiff ends end around the corner, you can expect erosion, as happened in this case. And you can see that they treated this. This is an old case, so they treated it with a Z stent. But the problem is that the end of this stiff stent eroded through the vessel wall, vein wall, and into the adjacent aorta, and the patient developed a pseudoaneurysm of the aorta right there, which was then treated by a stent graft, as Matt tells me. So benign, summary of benign SVC syndrome, treat only symptomatic patients, angioplasty first for stenosis, obviously dialysis related, that's what you want to do, and then a stent when they fail. Again, majority of non-dialysis benign occlusions of veins do not respond to angioplasty alone. Primary patencies are respectable, and a stent graft may have better patency. There's some new data showing that this may actually be better, but most of that data is in the dialysis literature. And don't forget the close follow-up of these patients. Bottom line is that it does work in these patients, and it is now the first line of therapy. So what I like to do is if you could load the next talk, go into a related talk, and that is central venous occlusions. And then a couple of minutes afterwards, if there are any comments, we'll discuss them. Apologetically, I have to leave early because of a flight. So the next talk is interventional management of chronic central venous occlusions. Now, I have some definitions, and these are my same disclosures. Between my two talks, I could not pick up any more people to support me, so it's the same. Definitions. So here's when I talk about these, so to be sure that because these patient populations are different and definitions are different, so when we talk about techniques and patency and all that, we know what we're talking about. When I talk about central venous occlusions, I'm talking in the upper extremities, brachiocephalic veins and the SVC, and in the lower extremities, iliacs and the IVC, and I frequently throw in the common femoral in there also. Chronic occlusions, we're talking about really thrombosis or occlusions of more than 3 months. A 1 month occlusion has some fresh clot in there, things of that sort. The techniques are easier to deal with those. These chronic occlusions are really more difficult. As a general rule, you may need more than one access in these chronic venous occlusions. Length of the procedure is unpredictable. I've done them in 15 minutes, and I've done them really in 5 hours. It really depends on the length of the lesion and how bad things are. Most common element of success is really planning, persistence, and practice. You got to have some practice in these things. If you don't have a whole lot of practice in chronic venous occlusions, you're going to be frustrated. And the current devices really are not designed for venous occlusions. We just take things off the shelf that they've worked in the arteries, and we try to use them in the veins. Sharp recanalization may be needed in many of these cases. So you should be familiar with the expected course and curvature of the brachiocephalic veins and the iliacs, especially at the point of confluence of these veins. When you want to stent and stenting strategies and all of that, you don't want to fall short. Because if you do, they re-occlude. So you have to know what the course is. And of course, for sharp recanalization. Angioplasty alone, my experience, rarely effective in chronic occlusions in non-dialysis patients. And bare metal stents associated with poor patency in veins peripheral to brachiocephalics and saphenofemoral junction. There's very little data out there on this, on how these things do, but typically they tend to occlude faster when you're more peripheral. Pitfalls. Be careful of collaterals. They may be mistaken for the main channels, and you may rupture them by angioplasty, which is okay. They're low pressure systems. You can easily coil them, or you can just stent them if you can get back into the channel. Rupture also possible if the main channel is over-dilated, so be careful, and let's look at some of these cases. Here's an 18-year-old with chronic left lower extremity post-thrombotic syndrome due to inadequately treated DVT a year earlier, which was due to a badly done appendectomy. Here's what the vessel looks like from below. This was approached from below first. Here's the venogram, completely occluded. So this may be the channel that you have to chase. Clearly, it's not these two, or is it in here? It's hard to know. A different projection shows that this clearly was not the case. And in fact, the main channel was somewhere in here. We could not recanalize from below, and so we approached this from above. Patient was turned around, and here's a guide catheter, as you can see, sitting here for better support. And this was recanalized down this path into this area, and we had a meeting from above and below. And initially, the 035 systems could not cross this very fibrotic area. So I had to switch to 014 and use a smaller balloon so we can gradually inflate and get back up, and then gradually switch to 035, higher pressure balloons, and everything was stented and flow was reestablished. I have 5-year follow-up on this patient, who then went to Philadelphia, was followed by one of our colleagues in Philadelphia. And this remained patent for the 5-year follow-up that we have, and this was a very active woman. What if both iliacs and the femoral veins are involved, such as this? So this is obviously this is post-thrombotic or thrombotic. Femoral vein is out, common femoral reconstitutes for a short period, and then the iliac is also out. Now, I treat these patients and recanalize the iliac into some place down here where there's good inflow to make sure that you have good patency. Typically, I do not stent the femoral vein for reasons that I mentioned, and you establish good flow. This is not a cure. These patients will continue to have some symptoms because of the femoral, but the magnitude of the symptoms improves. Now, in the National Venous Registry, 4 of the 5 patients with the femoral stents thrombosed within the first 6 weeks or so, and based on that paper, the 5th patient was lost to follow-up. Primary patency of stents above the saphenofemoral junction is actually pretty good. It was 74% in the National Venous Registry. This is one area that I think our colleagues at the FDA are underestimating. They think that these data is actually closer to 80 or 90% in thrombotic patients. It is not, and it does affect trial design, and I worry that some of the companies that are out there yielding to the FDA's requirement may actually be disappointed, or they have to put non-thrombotic patients in their trials. Primary patency in non-thrombotic conditions is over 80%. Most of the papers in non-thrombotics come from basically 2 labs, and they have they're discussing 95+% patency, which in my opinion, that's probably in a lot of places that may not need the stent to begin with. I want to share this quote with you from late great John Porter. After we had, back in the 90s, we published a lot of papers in chronic venous occlusions, and there was one paper we published on chronic IVC occlusions and recanalization. And John wrote that I have been utterly amazed by certain results described by Dake's group. At the time, Dake and I were in the same practice. The most impressive to me have been their claims of their ability to open chronically occluded venous segments. I find these claims surprising in light of my experience. Now, those of you who know John Porter, he was a very respected vascular surgeon. Very accomplished. He was the editor of the several vascular surgical journals. This, in fact, basically tells us that we were making stuff up. And in not so many words, you liars. That's what he's saying. But I'm glad that more people are on our side now than that they are on his side.
Just since we're a small group, I want to inject what Dr. Porter said to me one day when I walked down off the podium, saw him sitting down there in the second row, and I said, this is one of Dr. Bergen's symposiums. I said, gee, Dr. Porter, thank you for coming to my talk. And he said, well, I didn't believe a word of it.
He's in print right there. That's from an article that I took out, and this is in year 2001, guys, 2001. This was not in the 80s. Anyway, let's continue. So here's, I share this case with you. It's a 16-year-old patient who presented with flank pain and then developed 3 weeks later lower extremity edema. And long story short, is back pain elicited a CT scan, and ultrasound showed iliofemoral DVT, and CT scan showed, and I'll share the CT scan with you. So here are the femoral veins here. It looked okay to me that I thought maybe those femoral veins are open. This was really done from arterial. It's not a good CT venogram. But you can see here the veins expanded, a little bit of inflammation around them. Now you're beginning to see a lot of dots and blots around here. They're telling you that probably these veins are occluded. And here's a little bit higher up, and you can see that now here's the expected position of the IVC, and there's just not much there. And a little bit higher up, and you can see these large paralumbar plexuses coming, that there is a chronic process going on over here. And in this case, here's the expected position of the IVC. It's just not there, nothing there. And we're at the level of the kidneys, just above the renal veins. And large collaterals, this one into the portal system, and there were some into the azygous and hemiazygous system as going up. And here's up there, there's just no IVC. Okay? So suprarenal IVC, non-existent. And here it is, comes to an abrupt stop right there, and everything down below here, these are completely thrombosed in this patient. So this is an acute and chronic. So if you treat the acute component, don't forget the chronic component. So this patient underwent bilateral DVT thrombolysis, and here's the clot up in the iliacs, so on and so forth. We went all the way up, and in the expected position of suprarenal, I got stuck. So we treated this patient with catheter-directed thrombolysis, 1 milligram per hour into each limb, repeat venogram 21 hours later. Down below looked better, but up here there's still a lot of clot, and this IVC looks like there may be some chronic component to that. And here's right at the level of the renals. Everything is stopped. So we can't stop here. We have to obviously get rid of some of that clot still. Here's the problem. We're not at baseline, so we know suprarenal probably chronically occluded or hyperplastic, but we have not opened up the collaterals. So should we continue catheter-directed? We have some minor oozing. Hematocrit stable, fibrinogen is 80. Remember, this is a pediatric case in a pediatric ward with pediatric people on him who have never seen us do anything like this. So I get every hour, I get 10 phone calls. So this is what it looks like down below on this is the second day of treatment. And so a little bit better. Now we got some flow into the cava. The problem is that the cava is occluded, and this is what the cava looks like. So this has to be obviously, we need to establish outflow. You can't just leave it like this. And so this patient we used hydrophilic catheters to recanalize into the right atrium, and that failed. And so we used the sharp recanalization technique. And I addressed this through the common femoral veins because popliteal is just a long way out. And we were able to get through into the right atrium, and that was a transeptal needle. And establish flow. Here's an injection showing you're in the right place, and everything was ballooned and stented. This is a 20 millimeter wall stent up here, crossing with nitinol stents in a kissing fashion and getting some flow going. I wasn't very happy with this configuration at all, but this is what we sort of had to deal with. And we said we aggressively anticoagulate this patient and see what happens. And this is the outflow. Looked pretty good. Now, here's what it looked like in a CT afterwards. Here we crossing, doing the kissing stent in there, and with an outflow with the wall stent. And the reason I use nitinol stent is because of this configuration. You'll never get this with a wall stent. You see two circles with a wall stent, which tend to compress each other, rather than this double D configuration. Anytime so I use kissing stents, I use nitinol stents. So patient continued to have some back pain for about a week, which improved. That's probably because of the expansion of the cava by the stents. Lower extremity edema resolved. 6 months follow-up, patient remained asymptomatic. Ultrasound follow-up showed, now I have 1 year follow-up on this kid, and everything is still patent, despite the fact that I thought that he may actually thrombose fast. Post-thrombotic, same way. This is an older patient. This is obviously not cava. This is the azygos. This was recanalized from above and below and stented with great patency. Same thing in the upper extremities. Now, in terms of stent graft, most of my stent graft experience is actually in the upper extremities. I only have done 3 patients in the lower extremities, all of them with malignant erosion into the vein. This patient was treated for 10 years with angioplasty alone. And finally, what we did is that we went ahead and put a stent graft in here and decreased the intervention rate from 2 a year to 1 every other year. And this patient remained patent for the ensuing 10 years and then died of an unrelated cause. Literature, stent grafts, all of them are in the dialysis patients. This is 3 recent papers showing pretty good patencies. Now this one here, about 60 and 40% at 6 and 12 months. This paper by Jones is probably more representative. We have 12 patients that we have treated, and our data is very close to Jones's paper rather than the patient by Verstandig. Condu did a symptomatic patency, and symptomatic patency in these patients is 100%, so the symptoms are relieved. These 2 were venographic patency. As you can see, venographic patencies, you do see some narrowing. So in conclusion, endovascular recanalization of chronic venous occlusions has high technical success rate. Balloon angioplasty, usually ineffective. They're totally occluded in non-dialysis patients. Stents in veins counteract the recoil that you get under angioplasty. And more peripheral veins and those involved with tumor have a higher rate of thrombosis and restenosis. Thank you for your attention. And thank you for allowing me to go earlier.
Thank you. I want to ask, I just want to clarify one thing. You weren't here for earlier, and I'm sorry you have to leave, but I made the opposite claim that I use wall stents because they don't collapse like nitinol stents do. And most of the failures I've seen in patients who come to me for occluded iliac stents, 80% of them are nitinol stents, and from all over the country. So it's interesting that we both have done a lot and we have different
Well,
ways of
that would
doing
be
it.
subject of another debate between you and me, not just IVUS. And I agree that sometimes when the patients come from other institutions, the question is, did the stent cover the appropriate length of the diseased vein or not? And we've done a lot of IVUS work in nitinol stents and measured actually the area of flow between smart stent, most of our work was smart stent and wall stent, especially in May Thurners. And so our results in terms of the volume, the diameter, and the area of flow is that although nitinol stents collapse like this and wall stent doesn't, the area of flow is actually higher in those nitinol stents. But these obviously need to be addressed and flushed out a lot more.
Okay.
Yes, sir.
I have a couple of comments and then a couple of questions. Having done a lot of dialysis work, I've been very disappointed with the results of central vein recannulation procedures, whether they're with stents or angioplasty or whatever. I've seen a number of stents that have been deployed in thoracic outlets.
Mm-hmm.
And I just wanted your opinion about why do people do that? I mean, it's in an area that's surgically a no man's land. They tend to fracture frequently. They make the problem a lot worse.
Sure. So the comment is that the disappointment with the outcome of stents in dialysis-related cases, and also extension of a stent across the thoracic outlet, and obviously we don't do that. The only time I stent across the thoracic outlet in dialysis patients who are, again, if that is considered to be the culprit for access failure, you have to get patency. If you angioplasty that and before your eyes it closes, you have to do something. No doubt that if you put a stent in there, within 6 months that's going to recur. Our experience in a limited number of patients with the stent grafts in that location, if you can maintain the patency, it has been better than stents alone. So personally, I stent graft across the thoracic outlet in dialysis patients if, number one, that is the culprit for access failure, or the patient is symptomatic, arm swelling, and number two, if angioplasty fails in front of my eyes.
So, and then just as a comment, I've been so disappointed with central vein stenting for dialysis patients. I've changed my algorithm to do precision banding, so the Miller procedure, where you take a balloon and you get to the juxtanastomotic segment near your anastomosis, and you make a little cut down, you tie a suture on as your balloon's inflated, and that has worked incredibly well for swelling. So if your major problem is arm swelling and you reduce the flow with precision banding, it reduces arm swelling. Now obviously there's recirculation and bleeding time, things, other issues to deal with. The third thing real quick is, what stent grafts are you using, and what sizes are you using them for?
Its size depends on, I use Vibon most of the time. If
For the
central,
cephalic or IVC.
right. If we use a stent grafts, as I mentioned to you, my experience with the stent grafts is only 12 patients. Vibon most of the time, and you size them to the vessel, obviously. The BART device is also pretty good. We use Flare for anastomotic issues. The data is actually pretty good on that. And your experience with banding, I think, needs to get in the literature. I would write that up. Thank you.
Thank you so much.
Thank you.
Dr. Hernandez, please, thank you for being patient with us, and he had some conflicts with the other room too, but now we get to hear two very interesting talks by Dr. Excuse me, Rodriguez. I don't know why I said Hernandez. No, it's here. So management of venous trauma, which I'm very interested in as well. And then you want to give your other talk? This down?
Sure,
Yeah.
be happy to.
The management of Paget Schroeder, which just is a point that we were just discussing.
Yes.
Okay.
No, thank you, and thank you for the invitation, and sorry for the delay. Things got a little crowded next door, and we're going to start with the first slide for venous trauma, and I'm glad you expressed interest, because when I was asked to do this, I'm like, well, we're talking mainly to a group of interventionalists, and I don't know that there is a lot of things to say about endoluminal management of trauma, to be quite honest with you, but I will give an overall view of venous trauma from my perspective as a surgeon and the times that we have done endoluminal techniques for the management of venous trauma. More often than not, you will see venous trauma in the extremities, and in the vast majority, it is in combination with arterial trauma. And this picture is an example, a carpenter with a pneumatic nail that went through the popliteal space, injuring the popliteal artery. And once you explore the popliteal artery, you find that the vein is also injured. Another case, this was a 17-year-old kid that was playing with a shotgun, and you can obviously see why he will injure not only the arteries, but also the veins of his lower extremity. A compilation of literature recently published show that the majority of injuries in the extremities are in the femoral vein, about 17%. A good number of injuries to the neck, specifically the internal jugular vein, a little more complex. 15% of damage is caused to the inferior vena cava, and about 14% to the brachial vein. More often than not, you will diagnose these problems during exploration for arterial problems. The low pressure in the venous system allows for spontaneous cessation of bleeding in most cases of blunt and even penetrating trauma that only affects veins. Reality, and you have seen it when you are doing balloon angioplasties in veins and you create a perforation, when you're pulling IVC filters out, and those sometimes you need to yank a little hard and you pull it out and you do a venogram and you see some extravasation of contrast. And 99% of the times the bleeding is contained because the low pressure in the veins gets equilibrated with the pressure around it. The problem is when you have an open space. Retroperitoneal hematomas, usually if you don't touch them, they don't get worse. The problem is if you have an open space, and I think the main take-home message for venous trauma is that as a surgeon, you can make it a lot worse than it was. You almost always will find it during surgical exploration. Another case was a femoral artery injured by a bullet, and obviously once you dig, you see that the vein was also separated. And you do your arterial repair, and then you need to decide, what am I going to do with this femoral vein that is completely separated, or the popliteal, or the jugular, or any vein that you find injured. And what is that I'm going to do? Well, the first option, and I think the most commonly used approach in surgery, is just to simply ligate the vein. You just tie one end and tie the other and call it quit. Is the most expedient way of managing venous trauma. And it is very adequate, especially if the patient is unstable. You do your arterial repair, the patient is acidotic and cold and hypotensive. It'll be a mistake to try to fix that vein. The best you can do is just ligate the vein and get out of there. Nevertheless, there are some times that we attempt operative repair. The requirement is that the patient should be stable. A patient with multi-organ trauma, with hemodynamic instability, should not be put through a venous repair. But if the patient is stable and you have time, it's a really nice surgery to do. There are some theoretical advantages of fixing the vein. One of them is that you prevent venous hypertension, and these patients that have combined arterial and venous injuries can have very severe venous hypertension, chronic edema, acute edema with compartment syndrome. And one theoretical advantage is to prevent this problem. Another one is that if you did an arterial repair, you want that outflow to continue. And if the vein is occluded, a theoretical problem is that your arterial repair can go down because of lack of venous outflow. once again, preventing a compartment syndrome is another theoretical advantage. Now, the surgical repair has to be done carefully. The main mistake people make is that they try to treat veins as if they were arteries. One of the principles of arterial repair is that you need to achieve proximal and distal control. So you expose the artery above and below the site of injury and you put clamps. This should not be done in veins, because for sure you will create a lot more damage trying to control the veins. They're very, compared to arteries, they're thin, they're frail, and the worst that you can do is try to put a clamp across the vein above and below. So what we do is we just do external temporary compression. We get a medical student that had good breakfast or good dinner, depending on what time, usually it's in the middle of the night, and we just compress the vein above and below while we try to decide what to do with it. The second problem is that the repair needs to be tension-free. You can cheat a little bit with arteries when you do an anastomosis. The high flow will keep it open. With veins, you cannot cheat. There is no room for inaccuracies. You have to do the anastomosis perfect because there is a low flow vessel and it will tend to thrombose. So preserving luminal diameter and achieving a tension-free repair are principles that you need to follow. And the problem is that you don't have large enough conduits to achieve these more often than not. You should not use the ipsilateral vein to repair an injury. For example, you're dealing with a femoral vein that is transected. You should not harvest the saphenous vein on that side for obvious reason. You want to preserve flow through the superficial system, so you go to the other extremity or to an arm. And if the vein doesn't have an adequate diameter, then what you do is you can do one of several things. One is a panel technique, when you just split it in half and then put the two halves together and you double the lumen of the vein. Or you do this, which is a spiral technique, where you cut the vein in half and then over a chest tube, just spiral it, and you spend about half an hour putting tiny little stitches to make a larger conduit. Now you need to make sure that the length of your conduit will be adequate, because a frequent mistake is you make it too long and then once you put it in, it kinks. So you got to be careful about that. And this is one example. This was a combined arterial and venous repair, and you see the artery repaired, and then the vein, we did a spiral vein and the proximal and distal anastomosis. More often than not, when you have combined injuries, you need to think about doing a prophylactic fasciotomy. I just did this 16-year-old kid 2 weeks ago. He had a popliteal artery and venous injury. We repaired both, did a fasciotomy. I closed the lateral fasciotomy, but the medial wound I could not close. You can see how the muscle was bulging. So he came back 2 or 3 weeks later. We put a skin graft, and he's back on the street, hopefully not getting in trouble this weekend. The vena cava is another vessel that we have repaired in occasions. That poses another issue. You don't have a conduit large enough, and so PTFE grafts are a good option. More often than not, you should use externally reinforced grafts. This is an example of a vena cava that was repaired. The outflow anastomosis behind the liver, and the patient, for other reasons, had a CAT scan a few weeks later. You can see the patent cava. And the anastomosis, the outflow anastomosis is really high behind the liver. This could be very challenging. You need to mobilize the liver extensively in order to be able to reach all the way up there. So is there a role for endovascular therapies? Because I'm sure I am boring you with all this surgery stuff. And yes, I think there is. I think it's a limited role for several reasons. One is a low flow state, and so endoluminal devices have lower patency. Second, you more often than not need to just leave it alone or ligate it. But I'm going to give you 2 or 3 examples of patients that we have treated with endoluminal therapies. This was a iatrogenic trauma. This lady had, as you can see, a really large sarcoma. A surgical oncologist embarked on the endeavor of removing the sarcoma, got into the cava behind the liver. I was a fresh attending, and the chief of trauma and my boss, the chief of vascular surgery, spent 2 or 3 hours trying to repair the cava, and they gave up. And I was a new attending, and since they knew I had endoluminal training, they called me and they asked me, do you have any thoughts about this? And I said, not really. I don't think I can fix it right now, but why don't we pack the patient and let me think about it? And so we packed the wound, put her in ICU with the belly open, and then I thought about it, I did some measurements, and the following day I came and I directly punctured the infrarenal cava, put a sheath, and deployed a couple of aortic cuffs in the cava behind the liver. And that scored me a lot of points with both the chief of trauma and the chief of vascular because I bailed them out from a bad problem. But that is exactly the role that I see for endovascular therapies, a bailout when you cannot ligate the artery and the vein, and when there are no other options. Similar example, this was a penetrating trauma to the pelvis. The trauma surgeons fixed the artery without calling us, and they quit trying to fix the vein because they tried to get control, they made it a little worse, and they realized that they could just pack the patient and follow the principles of damage control and put the patient in ICU. So the following day, instead of going back to surgery, they decided, well, why don't we go to the angio suite? And one of my colleagues from radiology directed this intervention. You can see the lapse in the operative field, and he cannulated the hypogastric vein and found the area of bleeding, and then selected one of those branches of the internal iliac vein, coil embolized them, and masterfully control bleeding that otherwise is really difficult to achieve in surgery. You're working really deep in the pelvis, and that's not fun to do. One last case that I'm going to show you, also a patient with penetrating trauma, explored. The trauma surgeons decided not to attempt repair, pack it, then the following day, angio suite confirmed injury of the iliac vein, the common iliac vein, and a biobond was placed with excellent results. So in conclusion, you will find venous trauma more often with association with arterial injuries, is often in the extremities, and most of the times the treatment should be limited to ligation. Surgical reconstruction can be achieved in stable patients, and there is a limited but real role for endoluminal therapies. Thank you again.
Thank you very much for that talk. I wanted to just mention that we had a case of a lady who had undergone a hysterectomy, and the physician didn't appreciate her iliac compression issue with lots of collaterals, got into a tremendous bleeding, and ended up clipping both the artery and the vein at the common femoral level. So she was had ischemia as well as venous hypertension. So a year later, she was referred to Arizona Heart, and Dr. Amaya did a PTFE graft for her artery. But that left her with some flow into her leg, and she wasn't claudicating, but she developed venous hypertension because the common femoral vein was ligated. And you had said on an acute basis you wouldn't bypass the vein, you would just ligate it, which was probably what happened. This lady wasn't probably very stable after all that bleeding. So Dr. Ramaya said to me, he said, I bet you can't do anything with this. I'm sure it's impossible. I said, well, we could try. And I just want to point out that we were actually able to get a guide wire to go through the actual clip after we figured out the anatomy, which took about a day of lytic therapy because it was a year old. And we actually got a guide wire to go right through the clip. But the balloons, the small balloons, wouldn't do anything to it, wouldn't even budge the clip. But the next day we put in a larger balloon over an 035 wire with a pull-through, and we actually just opened the clip, which was amazing, and proceeded to stent it. So even a year later, following that kind of venous trauma, where people have been ligated, surgically ligated, it's possible to do an endovascular repair, which I don't think it's difficult, but it wasn't impossible. And I think there are people in this audience who definitely have the skills to do that, but it's an interesting observation.
You know, it's amazing what you can get away with endoluminal therapies in the iliac veins and the cava. I'm sure you have many patients that, like we see, that are referred with caval anomalies. The cava is non-existent, the cava is atrophic, and it's not. It's just occluded, and it just takes a little bit of work. And you open them, and it was there, and you couldn't see it on the CT or the venograms because it's chronically occluded. And it's amazing how good they respond.
Exactly, exactly. All right, well, now we'll continue with your Paget-Schroeder talk. Thank
Great.
you.
So thoracic outlet syndrome is a group of disorders associated with compression at the thoracic inlet, and it comes in 3 different varieties. The vast majority of patients have the neurogenic variant of thoracic inlet syndrome, but about 5 to 6% do have a vascular thoracic outlet syndrome. The majority of that is venous thoracic outlet. Important to note is that 65% of those patients with vascular thoracic outlet do have a component of neurogenic symptoms in addition to the vascular entrapment. Anatomically, there are 3 different areas where you can have compression. The most common one for veins is the costoclavicular space, and is a space that is delineated by the clavicle above and the first rib below. And then I'm going to go into a little more detail about the scalene muscle and the other structures. The second area where you can have entrapment is the scalene triangle in between the anterior and the middle scalene, and that's where the brachial plexus goes. And then finally, there is a third variety of thoracic outlet syndrome, also known as a pectorale minor syndrome, and that's where the tendon, where the pec minor inserts into the coracoid process, can also create obstruction. This is common in arterial thoracic outlet. This is the most common for neurogenic thoracic, and this one, the costoclavicular space, is the most common for venous thoracic outlet. Again, the roof of the space is the clavicle, the first rib below, the subclavius, and the costoclavicular ligament medially, and the anterior scalene muscle laterally. You have the vein, and then in between the scalene muscles, you have the artery and the nerve. Venous thoracic is also known as effort thrombosis or Paget-von Schroeder syndrome or disease. Typically, patients have a history of weightlifting, pitching, swimming, or any other overhead activity. Backpacking is common among young people. And they present with sudden onset of arm edema and pain, sometimes just discoloration of the upper extremity. We typically make the diagnosis on clinical basis and confirm it with a duplex ultrasound that shows thrombosis of the subclavian axillary segment of the vein. What happens after is most patients get anticoagulated. Usually from the emergency room, they get admitted with anticoagulation, or they get a little bit of Lovenox. And I think in most centers today, patients are immediately referred for catheter-directed thrombolysis. And this is an example of how we do this. Usually you do a micropuncture access to the brachial or the basilar vein, and you advance a wire after making your initial angiogram. The findings are occlusion of the vein right at the thoracic outlet and very extensive collateral formation. The next step is to use a hydrophilic wire and a catheter to cross the area of thrombosis, confirm that you are in the cava, placing a multi-site hole catheter and starting thrombolytic therapy. This is one day after. Most of the clot, but not all of it, is gone, and then you can do a variety of things. You can use a little bit of clot manipulation with balloons or any of the devices that are your preference to make the vein clear. The question is, what do you do after lysis? And this is where things get a little complicated. And I'm going to show you 4 different approaches. The first one is immediately after lysis to go to surgery, and by immediately I mean during the same admission, decompress the thoracic outlet by removing the rib, and also doing a venoplasty of the vein, which means you have to open the vein, put a little patch, make the lumen bigger. The second option is to discharge the patient on anticoagulation and then do the decompression with or without venolysis, And then finally, some groups advocate not even decompressing the vein, just keeping the patient anticoagulated. And finally, I'm going to give you a fourth very provocative approach that Julie Frashley from Hopkins is advocating, and is to not lyse the patient. What Julie does is she puts patients on anticoagulation from the emergency room. They go home, anticoagulated, no lysis. She schedules the case for decompression electively. And then 2 weeks after, she does a venogram. And I'll talk a little bit more about each one of the four approaches. And you also have to decide, if you decompress the vein, how are you going to do it? You can do it through an axillary approach, or you can cut below the clavicle or above the clavicle, or you can use a combination of those. So there is a lot of choices. And whenever you see a lot of choices, obviously it's because there is not one that is proven to be the best. So again, the most aggressive approach is you do lysis, and then you go to surgery during the same admission. Excellent results. Many series have published experience from different academic centers, and you have great results. 95% of patients do great. But the problem is, if you're going to do venolysis, you really need to expose this area properly. You cannot do that through the transaxillary approach. It's just virtually impossible. You need to open above and below, and in some occasions, even that is not enough. There is one technique popularized by Dr. Molina where you do a mini sternotomy, so you can get to this vein and do a proper patch. So it is really aggressive. There are several complications that can come from it: lymphatic leaks, bleeding, brachial plexopathy. The second most aggressive form of treatment is you do lysis, and then you go immediately after for decompression without lysing the vein, without putting a patch. And then you repeat a venogram and PTA if needed. And this is kind of what we do at Northwestern. We go for lysis. We do the decompression either in the same admission or shortly after. I sometimes let patients go home, depending on their and my schedule, and they come back in a few weeks. And then I do a transaxillary decompression, leave the vein alone. And then I do a venogram if the symptoms recur. And these are some examples. Patient comes, you do the venogram, cross the lesion, do the lysis, and then after the decompression, the patient has symptoms again, then you go back to the angio suite, shoot another x-ray, you see that there is still some anomalies in the vein. Well, you use a balloon, and you can see the give on the balloon, and usually you get excellent results. But not without problems, and we learned this the hard way. This is a patient that had lysis followed by surgical decompression, and on postoperative day 2, he had swelling and symptoms again. Young guy, and he said, you know what, I know it's back. My arm feels just the way it felt 2 days ago. I felt resolution of the symptoms yesterday, but now I'm back. So we go to the angio suite. Indeed, we see a defect. We balloon it very aggressively. We balloon it. You can see the JP drain somewhere there. We get this beautiful result. High five, everybody. Let the patient go home. He comes back the next day to the emergency room with a massive hemothorax, a hemoglobin of 5, bleeding. So we learned the hard way that doing balloon angioplasty of the vein soon after decompression in the presence of anticoagulation is a very dangerous thing to do, and I encourage you not to do this. This is not the only case we've done this. I unfortunately have 2 or 3. I don't do this anymore. If the patient has symptoms, I just anticoagulate and wait, and I delay at least 2 weeks trying to do any form of venoplasty, and they should not be anticoagulated at the same time. Now, the third approach is, can they go without decompression? And this is what the group from Stanford and others have proposed, where you don't do decompression. You do lysis, and you only decompress those patients that have symptoms after lysis. And what we know is that about 30% of patients will have symptoms, but the majority will never need repair. The problem is you cannot tell who those patients are. I'm going to give you an example. This is a young female lawyer that I treated a few years ago, 2011. We lysed her, and then we macerated the clot and made angiogram look really pretty. And then I sat with her, and I gave her all this information and all these different approaches. Smart lawyer, and she said, you know what, I really don't want to have surgery. Let's take a chance. Well, as long as you know that you have a 30% chance of needing the surgery, I'm okay with it. She decided not to have surgery. We stopped her anticoagulation 3 months after, and I keep seeing her 2 years after, she's completely asymptomatic. So there are some patients that you get away without decompression. I think really the decision has to, you have to consider these 3 different causative factors. I think the most important one is compression. Obviously, this is mainly a mechanical problem, but also you need to take into account the activity level of the patient and whether or not there is hypercoagulability. Only about 6% of patients with this problem have hypercoagulable conditions, but we test everybody. So if it's somebody older, like this lawyer who was in her 50s, not very active, she's not a swimmer, she doesn't play tennis, I'm willing to give it a try without surgery. It's not unreasonable to use a selective approach. But I can tell you how wrong I've been before. This was a 21-year-old girl who was backpacking in Europe and came back. She's a medical student. We lyse her. And after lysis, when she elevates her arm, even if the vein is patent, she still has a really significant element of obstruction. It's a mechanical problem. I talk to her, I evaluate her, and tell her, listen, you're not hypercoagulable, you're very active, you're very young, the problem is compression, I want to operate on you. And we put a date for surgery. She comes a week before. Her dad is a pathologist. Her mother is a neurologist. They've read, they want other opinions. They canceled the surgery. And I say, you know, of course, go look for opinions, but I think you need to be decompressed. Well, I keep seeing her, and she's asymptomatic. So there is a role for selective surgery. I just don't know that we can tell who should not be decompressed. Finally, I'm going to tell you a little bit about Julie Fraslag's new approach. And what she did is, based on 40 patients that were sent to her with thrombosed weeks, and all of them have an average of 22 weeks of occlusion. She works at Hopkins. She has really developed a reputation for this condition, so she gets sent a lot of patients. And these patients were chronically occluded, 22 weeks, and she decided to decompress everybody without lysis and then do a venogram 2 weeks after. And what she found is that only 1 patient required TPA of that group. Everybody else decompressed, and the clot went away just with anticoagulation. And so currently at Hopkins, this is what they do. If a patient comes, as I told you, they put them on heparin, start a hypercoagulable workup, and then they send them home on Lovenox. They schedule an elective transaxillary resection, and then they do a venogram in 2 weeks. And you don't see anywhere in this algorithm lysis. And so that just tells you that the management of venous thoracic outlet continues to evolve. There are many ways to deal with this. You need to consider all factors that can cause a problem. There are multiple ways to treat this problem. I think today thrombolysis followed by selective decompression is the way to go, but I am really looking forward to seeing more results from Baltimore about not having to lyse patients. Thank you.
Have any questions for Dr. Rodriguez? Dr. Rodriguez, I go back to one area in the subclavian vein. When you have a chronic thrombosis of the subclavian vein, you can often develop very large collaterals in the lateral thoracic distribution, in addition to the intercostals. So if you repair that area with either surgically or with stents in this area, do you have to take out those big collaterals, or will they steal from your repair enough to?
No, I don't think there is a role to do anything with the collaterals. I will shy away from putting stents across the clavicle. I don't do it. I don't like when people do it. I have to deal with many problems, including cover stents, as early as last week, 2 weeks ago. They get occluded, they get infected. The thoracic outlet is a really tight space, and if you put a stent, you're making it even tighter. So I'm completely against putting stents in that area for any reasons.
What about patients who have pacer leads removed and they have a lot of intimal hyperplasia? How do you deal with those then?
I think most of those patients get better on their own when you just leave them alone and they form collaterals. There are surgical options for very severe cases, but it's very rare that you need to do a bypass from the brachial vein to the jugular or something like that. It's extremely rare.
Any other questions, comments? Thank you so much for
No, thank
coming
you.
to be part of the Venous Forum here. Thanks. Dr. Hunter, would you like to give, Dr. Hunter's going to give us a talk on hemangioma treatment. And those of you who have stayed are very fortunate because he's one of the country's best authorities on this, I think.
Because there were no other talks on vascular malformations, I kind of took this as a liberty to talk about vascular malformation therapy. Vascular anomalies, we're going to talk about them in general from the concepts about the pathology of them, pathophysiology, how we classify them, diagnose them, counseling patients, and then what we're going to do for treatment. The various pathologies are completely based on exactly what type of vessel we have, and they vary so widely in terms of how people have talked about them, the names that they've given to them, that I think falling back to being just purely descriptive by talking about exactly which vessels are involved is actually important. In addition, you have to describe them not only by the vessels involved, but by several of the physiologic characteristics. And Mulliken and his group back in '93 were the first to really put the full force of the recognition of a few good experts as to the fact that the most dominant thing that you have to think about is flow, high flow and low flow. In addition, the pathophysiology is going to be altered by a couple other factors, particularly things having to do with when the lesion presents, when it seems to hit its peak in terms of its evolution, and its rate of growth and response to various kind of medications. So you need to keep all of these in mind when you're trying to classify them. With apologies to Mulliken, because there's a couple variations, the way that we classify them at Minnesota is into the categories that you can see here. And we've found in treating a lot of patients with lymphatic abnormalities, particularly the head and neck, that a lot of them have venous and vascular components as well. And then, as you notice, hemangioma really sits out at the bottom because hemangioma is a true tumor. And so we don't really include that except as a separate category. And in our first 46 patients that we treated when we did an analysis of them several years ago, you could see that actually the main reason that classification in some senses is actually important is the fact that those people who get treated do well but then get worse again. There's a far greater preponderance of those that have capillary involvement of any kind, like arteriocapillary venous malformation or pure capillary venous malformations, and other people have seen this as well, that when you have multiple tiny feeders going through capillaries, either from the arterial side or the venous side, they're much more difficult to treat. The differentiation, especially in children, between an hemangioma and a vascular malformation, usually a venous malformation, is actually fairly easy to make clinically because, as you can see, the differences between them in terms of when they present and when their growth is the maximum, which is obviously as an infant with hemangiomas as compared to teenagers with venous malformations, and the kinds of things they respond to, all these things are actually quite different. So that usually you can make that differentiation without too much difficulty. There are, however, I think very, very important new ways of classifying vascular malformations that are going to be unbelievably important in the near future because as we begin to understand, as those bottom three references have shown, and it was started in the 90s by the surgeons who did cultures and then genetic evaluations of cultured cells from vascular malformations, there are going to be specific genetic markers that are associated with these. And I can just feel the momentum building so that in the very near future, we're not going to be treating with any of these barbaric things that we do currently, like burning them or injecting them. We're going to be treating them with very directed genetic therapies, and they're just going to melt away and disappear. The hemangiomas also, I think, are going to be changing in their diagnosis because now, although we can diagnose them by when they appear, how they grow, and their imaging characteristics, they too are undergoing a huge revolution in terms of understanding the genetics of the malformation that occurs in hemangiomas and why they're so reactive and responsive and grow so fast in infancy. And as we begin to understand these genetics, you can just bet that there's going to be a whole new set of genetic therapies of hemangiomas as well that may get rid of this problem. And because of the fact that they can have concomitant intracranial problems, getting rid of this on a systemic basis with an appropriate genetic manipulation, I think is going to be very important. So when we first see a patient, as I said, we concentrate on the history and the physical exam, and then we do some imaging. And the imaging can be looking at the lesion. And if you look at something like this that is clearly a superficial lesion that has a vascular pattern where it's now involuting, this is clearly going to be falling into the hemangioma group. And this is something that can be either ignored, or if it's really bothering the parents, because in this case it was bothering the hell out of the parents, but the kid was completely oblivious to it, I suggested to them that they didn't want any therapy. They disagreed with me, and they paid the $1,000 to have the lesion excised by a plastic surgeon. And it was a complete cure, but, you know, cost them a couple $1,000. There is one critical component to imaging all vascular malformations, and that's the MR. It can usually be done without contrast. Ultrasound is particularly good to predict what the flow patterns are going to be. If you're at all concerned, if you're feeling pulsatility on your physical exam, you clearly want to have an ultrasound. And CT and angiography are only used in very, very selected cases. Angiography only when you're planning therapy. The MR is clearly the key. As you can see in this MR picture, the T2 weighted high signal intensity lesions are the classic low flow lesions. You can see their extent, you can see what part of the tissues they involve, either subcutaneous, intramuscular. And if you're particularly worried, which we were not in this case, we got this accidentally because the person that protocoled had ignored our protocol suggestions to simply do a T1 and T2 sequence. They did a post-contrast T1 sequence where they did add contrast, but what you can nicely see is that the contrast-enhancing portions of this match up precisely with the T2 high signal components, so it's all vascular. There's no lymphatic components, there's nothing that's scarred, there's no stroma. And the one thing that you really want to be cautious of is any vascular malformation that looks on MR like there's or ultrasound, that there's a very significant component of non-vascular stroma type tissue, because we have made some misdiagnoses in the past when that combination has been present, and it turned out to be a tumor of one sort or another that had high flow and not a vascular malformation. Ultrasound is used in cases like this to make sure that we can see the vascular malformation diving down into the joint on both sides, and exactly where the abnormal vessels are that we would be using to puncture. And we often do a screening ultrasound just so we have a baseline study so we know exactly how we're going to puncture these as well. We always, when we're doing the ultrasound exam at the time that we do the ultrasound-guided treatment of low-flow malformations, particularly the venous malformations, we always do it with compression so that we can see that this big dilated vessel completely collapses below this non-collapsing sort of neurovascular bundle of some sort. And as long as that's happening, we know we can poke into here and inject that with freedom, and we'll see the injection in just a little bit. Counseling, when I have the patients in the clinic, has to be done in a clinic before they have any kind of stress of the procedure on top of them. And you really have to get at two issues. Number one is how much pain is there and how much are you willing to deal with, because we often end up not treating. As a matter of fact, when we last took a count, we treat about 25%, roughly a quarter of the patients who are referred to us for treatment. There's two reasons that happens. Number one, because we really ask them about pain and how much it's bothering them. And then the second thing that is absolutely unequivocal is that you have to talk to them about what treatment options are available. And in addition, you have to talk to them about the fact that there is no malignant potential. A truly well-diagnosed vascular malformation has no malignant potential, and I cannot tell you the number of patients who came to see me in clinic over the years whom I have been speaking to about the nature of their lesion. And then I say, okay, now everyone wants to know, is this thing that's growing in their leg going to turn into a cancer? And the absolutely unequivocal answer is, on 100% of cases, no. You do not have a cancer. You will never have a cancer. This is not going to turn into cancer. It only matters how much it hurts you. And they've never asked you about that, and you tell them that, and they say, boy, that was the thing that was worrying the most. And they never asked you. And as soon as you tell them it's never going to be cancer, they're out the door. They don't care. It's not bothering them that badly. The other thing to remind them is that low-flow lesions are not dangerous. People say, you got to get that treated. If you get injured, you're going to bleed to death. You don't bleed to death from that any more than you bleed to death from a bloody nose. You push on it, it stops bleeding. So treatment really depends upon whether it's high flow or low flow or no flow, like lymphangiomas. For hemangiomas, watching and waiting and letting them go away is not always good, particularly if they're high flow. Kasabach-Merritt syndrome problems can arise in some people, particularly with central ones, but more importantly, they can just get into bad problems from the degree of flow. You can watch and wait. This kid had a watch and wait of a lesion on the heel of his foot. It was clearly a hemangioma by diagnosis, by biopsy, as well as physical exam and other findings. And he still had some discomfort when he was running as an athlete. And so instead of doing sclerotherapy or anything, because they are hemangiomas, they do respond to steroids. And so just a single injection of Marcaine and a steroid, like you would for a painful joint, made this lesion completely go away symptomatically. This young kid, however, take a look at his heart. He was in congestive failure. He had this massive hemangioma of his forearm. And you can see that in this particular picture here, when you inject the artery, which was injected here, you get immediate, huge amount of flow back, and he was in bad congestive failure. The recommendation to the parents was that he have his arm amputated at the shoulder. The parents, in a panic, called around and sought other options. The kid came to see us. We did what we'll talk about in a second. We did testing with radionuclide tagged albumin, Ivalon, which is easy to tag. We tagged different sizes, made sure that we were using a size that was bigger than the size that gave us this in the lung. And then we ended up with an arm full of tagged Ivalon, which was fine because the arm was tagged, but there was only one area, this one that we saw before, that went actually to the lung when we went down to too small a size. And within about a week, you see that even though there's a tangle of vessels that are still here, the outflow into the vein has been essentially eliminated just by arterial embolization. And the kid's chest was shrinking down, his heart was shrinking down, his arm was shrinking down. And about 6 months later, he's a cute little kid with a functional arm and a completely normal size heart. The arterial venous malformations, I prefer a transvenous stick if it's at all possible. To do that, you have to have absolute suprasystemic compression inflow control, and you have to really choose your agent carefully depending upon what you're doing. I often, as Patty knows, because she was there in the era when we were setting up all these algorithms, use surgical adjunctive help in order to clean up things after we've done the basic work. For instance, in this one, we did 2 or 3 transarterial embolizations to get the flow slowed down, get some of the veins under control, and then had the surgeon go in and do a wide debridement because there was just almost no way to get this completely controlled with either direct stick, because there's a million places you'd have to stick, or transvenous work, because you would have had to totally occlude every vein in the left brachiocephalic area. And after post-surgical, you can see that the amount of flow was markedly reduced, and we went back and controlled a couple of those big, huge veins with coils and some sclerotherapy, and the patient did quite well. My favorite, as I said, is transvenous sclerotherapy. You need to have an absolutely well-defined nidus and a vein that comes out of that nidus that will take you back close to it. If you do have it, then you can inject retrograde instead of going through the arteries with particles like we are here. You can go retrograde through the veins and fill the nidus retrograde. This is an arteriogram of a patient who had a bad malformation involving her calcaneus. We came down through this big, huge outflow saphenous vein because we could see that this branch led right back into it. We got a catheter all the way back to the nidus, then completely wrapped that foot and ankle in an exsanguinating, stretchy ACE wrap like they do for ortho purposes. And then we did retrograde sclerotherapy, injecting, let me go back a second, just one if I can. Let's see, how do I go back? Here we are. And we're injecting retrograde. You can see we're filling the nidus retrograde because we leave the cuff up suprasystemic. So when we take the wrap off so that all these big dilated veins can fill, but we leave the cuff up, there's no flow in from the arteries, so the thing can go back towards the arteries into the nidus because there's no arterial inflow pressure, and it can also fill all the draining veins. So it fills nidus, inflow arteries, and draining veins kind of all at the same time. And you have to be careful so you don't get any major arterial trunks filling. And after the first sclerotherapy, and then we repeated a second sclerotherapy right then because there was residual vascularity, all we had were these several punctures from when we had tried to get into her saphenous, and we're sort of flailing around at the beginning of it, trying to figure out which direction to go. But it completely cleaned up, and 6 months later, follow-up arteriogram shows completely normal flow to the foot and absolutely no hint that there's a vascular malformation there. And you'll notice that in her calcaneus, she's getting a lot of bony remodeling as the bone starts to regrow where the malformation was. If you're going to do arterial therapy of AVMs and arteriocapillary venous malformations, you have to be real careful with what you use. I still use particles on occasion rather than sclerotherapy techniques. Glue is good, and onyx is going to take over a lot of them. If you do use agents like alcohol, you have to be real careful. This was 1 cc of alcohol, about 2/3 of which accidentally spilled over into a perineal artery. That gave us complete loss of the Achilles tendon, and much of the soft tissues in that lower leg. Took 10 years of orthopedic reconstruction and physical therapy to improve that. And this was about 1.5 cc's of alcohol that accidentally went down into the ulnar artery. Embolization with particulate material size matters because you can go through AV communications to the lung. We had a few deaths in the Midwest from pulmonary injections coming through AV connections into the lungs, causing necrosis and death, unfortunately, in young people. So as I said, we radio label. The Ivalon is the particle that we use if we want to radio label until we start to see it showing up in the lung. Then we go back to the size larger that was not going to the lungs. We published that about 20 years ago, and people still, fortunately, use it occasionally. I also do all my particulate embolization without causing spasm and thrombosis, which can kill you because you embolize and you go back and you find that you didn't do anything a week or two later. And that's because you had a lot of spasm that relieved and thrombosis that spontaneously recanalized. And in order to avoid that, I always use a mixture of an embolic agent with nitroglycerin and heparin for every embo that I do. And I even do that for UAEs and other embos in other areas that I do, so I don't get spasm and thrombosis complicating my embo picture. And you always try and make your particles visible somehow to make sure you can see them. The best way is with contrast, so that if you're injecting particles and you're coming towards the end and you know you see this, you can slow down and make sure that you don't get any more type of reflux. And vascular beds differ. I mean, we saw this kid with a big thigh AV malformation, and in 2001, we looked like we got a great result. In August of 2001, still looked good when she came back for a follow-up angio, and yet literally 9 months later in 2002, it looks like we've never been there. So there's a certain amount of revascularization that occurs no matter how hard you try. That's one of the reasons that we've been switching in a lot of these to the combinations of sclerotherapy and glue. This was a hand malformation where we put a lot of glue in about 3 or 4 different sessions, trying to make sure we didn't occlude any arterial flow, just abnormal vessels. And you really have to make sure you're only in abnormal vessels. There was still a pulsatile lesion, however, that you could see exactly where it was coming from. We didn't know why this was coming banging out of this artery after all the glue we'd put in, but we stuck right into that, did the suprasystemic cuff prevention of outflow, and you can see that we've got the sotradecol right in the middle of all this glue in this sort of aneurysmal kind of area. And when you did the final angiogram after we let the cuffs down about 10 to 15 minutes later, and you have to have kids under general anesthesia to do this kind of stuff, you can see that that area now is completely non-filling because of the sclerotherapy that was allowed to sit in there for 10 minutes with a suprasystemic cuff up, and arteries are in good shape. Onyx and the related compounds, I think, are going to work well. This is a case we had not a few years ago where you can see an extremely large malformation of the mandible, and we filled that with absolutely tons and tons of onyx on 2 different occasions. After that, he was completely ready for the oral surgery he needed to repair all the tooth problems that he'd had from this malformation. We're about to publish a second article on onyx and peripheral malformations. I have the manuscript in my computer ready to look at, but there's otherwise just very few articles about using it in the periphery, but I think it's going to be very safe. Problem is its expense. If we get the glue that they have in Europe that costs like about $100 or so for a 2 cc vial and polymerizes about as fast as onyx does, I think we'll be well on the way to better therapy. Venous malformations, puncture them, hit them, inject Sotradecol or foam. We use foam almost all the time now. You need to control outflow. You can do it with pressure or cuffs, and then you can follow it up very nicely with the ultrasound again. It shows up beautifully, lets you see what you've done, keep that elevated for a while. And with liquids, you get a lot of complications. With foam, you get almost no complications, just a little pain and swelling, and then after that, the swelling goes away and they do extremely well. There's a lot of things you need to know about to manage complications, a lot of drugs you have to be happy with, especially steroids and anticoagulants, occasionally thrombolytics, and all malformations regrow. Exactly why is still up in the air. There's a lot of interesting stuff that started in the late 90s about hidden compartments, areas of recanalization or spasm and thrombosis, how they recruit, how they have some malignant genetics or some genetics that encourage angiogenesis, but all that is still up in the air. And there's new stuff coming down the pike that I just love to read about and watch. Haven't tried any of these things yet. I'm particularly excited about some of the new non-adhesive onyx-like compounds that are coming around, or some of the glue that's in Europe now that has onyx polymerization times that I think will really revolutionize the way we treat these from the arterial side. But unequivocally, I think in a decade, people are going to look back on the stuff that we're doing now, even some of the more progressive stuff we're going to do, and they're going to say, oh my God, can you believe what the hell they did and put those patients through when all they had to do was a little injection of these genes and all the problem just melted away in their whole body. Thank you.
Any questions for Dr. Hunter? Well, I think we've reached that point where we could take a short break, or we could proceed on with the other talks if we have all the speakers here. Would everyone like to just take a short break, 15 minutes? Then we'll restart.
5-minute break if
Five.
people want to go to the bathroom, but then
Yeah, come back in 5 to 10 minutes and we'll do the dialysis talks. Thanks.